Hi, my name is Dr. Ryan Palmer. I'm an orthopedic surgeon, fellowship trained in hip and knee reconstruction. So the focus of my practice is really hip and knee pathology. A lot of what I deal with is hip and knee arthritis and subsequently hip replacement and knee replacement surgery. It's a very common term that we all throw around, but I think overall is poorly understood, and I think most people would have a hard time really defining what it is. By definition, arthritis is inflammation of the joint, but where it becomes clinically detrimental to patients is the fact that the cartilage within the joint is beginning to wear down. So the cartilage is the white gristle on the end of the bone, and that goes for any joint in the body. So for the hip, if the cartilage begins to wear down on the ball side, on the socket side, or on both sides of the joint, we start to have inflammation caused by that breakdown, and that's really where we summarize the term arthritis. So when we begin to have symptoms, a patient with hip arthritis would have pain in the groin area. It may radiate into the thigh, and it may even radiate all the way down into the knee. It's almost not uncommon to see patients that have no groin pain but just present with thigh or radiating knee pain. But pain in the anterior aspect of the thigh is typically the hip joint until proven otherwise. That can be associated with lack of range of motion of the joint, and certainly patients can then begin to have limping and even start to notice leg length discrepancy as the cartilage wear becomes more advanced. The way we diagnose arthritis of the hip is to start with simple x-rays, a pelvis x-ray, as well as a couple different views of the actual affected hip. And what we're looking at is we're looking at the bony anatomy, and we're looking at if there's any narrowing of the joint space. X-rays just show bone, they don't show all of the soft tissues. That would be something like an MRI that would be needed to further dive into further detail there, but x-rays tell us a lot of information. So if there's joint space narrowing, we know at baseline there's some loss of the volume of the cartilage within the joint, which, if you recall, is by definition arthritis. So we'll look at x-rays, we'll look at the joint space, we'll see if there is still preservation of space or narrowing. Sometimes the diagnosis is easy. If you've heard of the term bone on bone, that is an x-ray term, and that is where there is no remaining space between the ball and the socket of the hip joint. At that point, we know there's advanced arthritis and we can begin to talk about treatment options. Sometimes the x-ray findings are a little bit more subtle. There can be hardening of the bone, there can be bone spur formation, there can be bone cyst formation. These are signs of stress. It tells us at what stage the arthritis is, and also helps to guide your treatment. Sometimes if we feel that there's still preservation of joint space, but that the clinical symptoms warrant it, sometimes an MRI is necessary to further look and really look, if you will, under the microscope to see what's going on at the cartilage level. So a lot of people ask me, why did I get arthritis? And the reality is that we all have some genetic predisposition for wear and tear arthritis. And some families have a stronger genetic predisposition for that, some don't. We will all get some level of arthritis at some point, but some present earlier, some present later, some present with mild symptoms, and some have advanced arthritis. The whole entire spectrum we treat. Independent risk factors for development of arthritis could include previous injuries, previous surgeries within the area. Weight can provide an independent risk factor for that, meaning that more weight on the joint can lead to earlier wear and tear. But again, most of the risk factors for development of arthritis are genetic and not something that you could directly affect. So if we've reached the point in the visit where we've diagnosed hip arthritis, then we'll talk about some treatment options. Certainly on the very conservative end of things, physical therapy is at the forefront of treatment. Physical therapy is meant to work on strengthening around the joint, strengthening the core, strengthening the quadriceps muscles, the hamstring muscles, the glute muscles, all of which help to support the joint. Even with mild arthritis, a strong core and a strong foundation will help somebody live with arthritis much better than if they weren't doing those kinds of activities. Sometimes we add in a simple anti-inflammatory medication, an oral anti-inflammatory medication. These are referred to as NSAIDs, or non-steroidal anti-inflammatory drugs. Most people can tolerate these. This can be as simple as a once-a-day prescription anti-inflammatory medication that we use sparingly as needed, as arthritis does tend to flare with inflammation and thereby causes pain. So that's something that we need to understand in terms of why we use anti-inflammatories to treat arthritis. As I said, arthritis is an inflammatory condition, inflammation of the joint caused by the breakdown of the cartilage, a condition we call chondromalacia. If we're going to help somebody's pain, then we want to treat the inflammation. So that's why we use anti-inflammatory medications to help treat the pain. So there are other oral anti-inflammatories that can be used. Those are the steroids as opposed to the non-steroids. Those can't be taken every day, but those can certainly be used in sparing doses to really help somebody's inflammation flare. There are also topical creams that exist on the market. These are over-the-counter medication creams that are anti-inflammatory in nature. Those can be very helpful, used alongside of oral anti-inflammatories as well, again in a sparing basis. Some of the secondary effects of beginning to have arthritis of the joint, which again will cause inflammation, which leads to pain, and the pain will then lead to lack of range of motion. And even some of the arthritic process is certainly going to lead to stiffness within the joint. One of the best ways to mitigate the stiffness of the joint is to begin a good stretching program. We send people to physical therapy for stretching activities to stretch the iliotibial band. This is a lateral tendon of the thigh. This is something that progressively gets tight in almost everybody that develops stiffness of the hip. And if we can work on stretching the IT band, that can really help somebody live with their arthritis much more comfortably. Other conservative treatments would include hip steroid injections. Again, these are temporary injections that can provide anti-inflammatory fluid to the joint. This is typically done by an injection specialist. This is typically done under a local anesthetic, basically numbing medicine in and around the hip area. They're then delivered under X-ray guidance in order to provide an anti-inflammatory injection to the joint. This may not be permanent, but it certainly can help somebody live with the arthritis better, and along with an otherwise well-developed and comprehensive conservative treatment plan, can certainly help people live their lives more pain-free.